Okay. So, as I say, really good to see you all. I've got to start with two warnings. The first is that the new NHS white paper, which was widely supposedly leaked and then reported last week as being about the Johnson government rolling back privatisation, well, we wish that were true. It isn't, it's spin. So tonight we're going to talk about how the new plans will mean that the NHS, that more of the NHS is going to be outsourced to the private sector in future, not less. And secondly, right on cue, just days ago, we discovered that 48 GP surgeries, including 11 in the North East London area, have been passed on to Operos Health. That's the UK subsidiary of the US health giant, the Centene Corporation. That's one surgery in Hackney, 2 in Tower Hamlets, 6 in Newham, 1 in Redbridge and 1 in Barkingham Dagenham, all of them now owned by an American company. And not just any American company. Centene's been heavily involved in ICS development in other parts of the country, just as it was involved in similar changes in parts of Spain that were absolutely disastrous. We think the leaks and the spin are because the government knows it's got a fight on its hands. And that's why we organised this teaching. We're in the middle of a pandemic that the government has handled badly. We've seen atrocious decisions, cronyism and downright corruption, but that's not the topic tonight. We wanted to share what we know about what is happening to the NHS and to focus on the integrated care systems that are at the heart of the threat to its long-term survival. I'm going to apologise in advance. This is going to be quite an intense session because this is complicated stuff. We've had to work hard to understand where things stand and we don't know everything. Plus the goalposts keep moving. If I tell you that we've had to rewrite some of our material, even in the last week, even today. But raising awareness is going to be essential this year. And we thought that we should start with our own activists, because we're going to need to reach out to the public later. So let's start with how the session will run. I'm going to kick off with a short explanation of how we got to this point. And then Jan from Tower Hamlets has the mammoth task of explaining what an ICS is and what the risks are. We're going to take a 5-minute comfort break, and we really recommend that if you've got any questions from what you've heard so far, you stick them in the chat function and we'll come back to them at a later point. When we come back, Mary is going to do a short follow-up to further highlight some of the key risks. And then Stephanie from Tower Hamlets is going to show how far our local North East London ICS has progressed. For the last section of the meeting, Coral from Hackney is going to collate some of the questions that you've raised in chat, and we'll try to answer them. And then we'll open the floor and let you unmute yourselves for free comments and questions. Right, so I'm going to kick off. How did we get here? And if you'll bear with me, I'm going to share some slides with you. How did we get here? Well, we need to remember that actually the project of breaking up the NHS has been a 40-year campaign. This is not new. When Margaret Thatcher declared war on public services, she left the NHS as unfinished business. You know, cabinet minute reports now show that it was actually members of her cabinet who stopped her at the time from going further with privatisation. But that threat from that quarter hasn't gone away, because we know that Oliver Letwin, John Redwood, Jeremy Hunt are all on record as wanting to abolish the NHS. So then we had Blair's government, and yes, Blair's government gave the NHS an additional £5 billion a year, but it also left us with foundation trusts, the internal market, and the horror of private finance initiative, which of course has been quite serious for us in our area. When David Cameron allowed Andrew Lansley to steam ahead with his Health and Social Care Act in 2012, which incidentally appears to have been written by McKinsey's, he actually left a regulatory mess, which is now about to be unpicked. And that is something that, you know, Jan will be talking about later. So then there was Simon Stevens. Now here's Simon Stevens. We know that he's currently the Chief Executive of NHS England. He started out as a health policy advisor to Tony Blair. He was president of global health at the United Health Group, where his job was targeting socialized health systems in Europe. And this is the person who is currently the chair of NHS England. So in 2012 to 13, you may not realise that the World Economic Forum got involved. They commissioned 2 reports from McKinsey, one in 2012 and one in 2013. And Simon Stevens, who was still at Global Health at that point, was the project steward. Now, those 2 reports, firstly, redefined health industry to allow global corporations to take over more public services. And secondly, they focused on new ways to deliver integrated or accountable care using a controversial US model. Now, in the UK, we now call these integrated care systems. In fact, those 2 reports introduced many of the key concepts that we're going to talk about tonight that are being rolled across the English NHS. So, timeline. Right, so reports published in 2012 and 13. 2014, Simon Stevens becomes the CEO of NHS England. By October, he's published the 5-year forward view with its first official reference to what we will come to know as integrated care systems. In 2016, England was divided into 44 footprints. That's now been reduced down to 42. And they drew up some alarming sustainability and transformation plans. And quite a lot of people at this meeting now will remember the one that was put around London, which was pretty dire. In 2017, NHS England published next steps to the 5-year forward view, and we started to see a rapid top-down centralisation happening on the ground, despite lack of legal status. So in 2018, campaigners went to judicial review twice, and both times failed. But the second judicial review did manage to push NHS England to slow down and concede that it needed to get the law changed. And getting the law changed is part of what the white paper is about. In December of that year, NHS England published the long-term plan. And then by 2019, we started to see integrated care systems popping up all over the country. Now, on the timescale that was planned at the time, they were due to be set up in every footprint by April 2020. But then we got COVID. So at this point, I'm going to hand you over to Jan, who is going to explain what is happening now and, you know, where things stand. So if you'll give me a second. Jan. Oh, just a moment. Coral, could you unmute Jan for us?
And I don't see the slides. I can see the timeline.
Oh, can everybody see the slides? Could you nod if you can see?
Yeah, but it's your slides, Carol.
Oh, that's interesting. Okay, let me go back and get rid of that. I apologise. There we are. I said it would be a bit clunky. There you go.
Thank you.
Now see Jan's slides. Okay.
So there's 4 things I want to say before I get on to this first slide, really, which I hope I remember off the top of my head. One is, well, as Carol has said, integrated care systems, ICS, is already up and running. Not all of them. The last count was 29 are set up now, or at some stage of being set up, but they're supposed to be, the last thing I heard was they're supposed to be in place by April of this year. Another point to remember is that there's quite a lot of flexibility in terms of how ICSs set themselves up. And so they're all very different, which makes it difficult to talk about them and more difficult to campaign about them to some extent. Another point is that forgotten what I was going to say. There's little to no evidence about whether integration, which is the sort of notion behind all this, is successful at all. I mean, there's evidence to show that it doesn't make any difference in terms of disease prevention. It doesn't cut costs, which a lot of the reason why they're introducing ICSs is about costs. And it doesn't seem to improve patient outcomes. The last point I'd like to make at this point is that Carol's mentioned we had, first of all, the NHS England consultation on the plans, and then they overlapped really to a large extent but they also, they're echoed in the government plans for legislation that just came out a few days ago. So some of the time I'm going to be, and they don't exactly marry up, so some of the time I'll be talking about the NHS England plans and sometimes the government plans, but so just where there's some kind of difference between them. So having said that, there are not very many definitions of integrated care systems provided by NHS England, but this was one that I found. And I've put in red some of the issues that just this definition flags up. So they're NHS organisations in partnership with local councils and others. And partnership is whether there's a question of whether they're equal partnerships or not. Partnerships with others, and the others, I think wherever you see others, you have to also think this could also mean private companies. And they take collective responsibility, and there are all kinds of ways in the way that organisations within the ICS are to take this collective responsibility, are kind of bound in a way to all kinds of constraints. So they take collective responsibility for managing resources, delivering standards, and improving the health of the population they serve. And I'll come back a lot to this thing about the health of the population. A lot of it is about population health. It's an idea that comes from the States. It's, as I said before, a lot of it's about cutting costs. And I'll leave this quote for the time being. We'll come back to that. So the next slide, please. Hello, thank you. The rationale that's provided for ICS is very much in line with the 5-year forward view and the NHS long-term plan. So it talks about the changing pattern of need with an ageing population, an increase in complex and long-term conditions, decreased life expectancy in some areas, and the need to address health inequalities. So from that basis, the argument is that we need to have a change of focus from diagnosis and treatment of illness to improving population health. And what will also make health services more efficient is collaboration rather than competition of organisations within and beyond the NHS. And the last point is that decisions, if they're taken closer to the communities they affect, are likely to lead to better outcomes. And this refers to place-based care, which we'll see referred to in several places. Next slide, please. What's less spoken about are the 2 key roles that NHS England says that ICSs have. And one is system transformation. in which the partners within the ICS agree to changes in local health and care services, and also to supporting strategies, the development of supporting strategies, such as there's a vast increase that is needed for digital infrastructure. We've already seen how estates can be, NHS England and others have got their eye on NHS estates, so we can imagine something's going to be happening to them. And there's also transformation of the workforce, which I'll touch on later. And there's also a role in system performance, and the main impetus of that, I think, is looking at the overall financial performance of ICSs. There's also operational performance as well. So next slide, please. So ICSs are sometimes called systems within systems. So you have an overall ICS which covers a population of anywhere between 1 and 3 million. And if you look at the map, you can see the area in blue is the East London ICS. And then you have a level which is the place level, a population of 250 to 500,000. Sometimes you get integrated care partnerships talked about at this level, but that's very confusing. And often the place that they refer to, although it's not very well defined, it often overlaps with the with local authorities. So it's not quite the case with the East London ICS, but generally speaking, there's a sort of roughly the same sort of map between a place and a local authority. So at that level, you get an alliance of providers. So it could be NHS acute trusts, community mental health services, social care, and others. And it's at this level that the design and delivery of most clinical services takes place. It's the level at which population health is used as a method to target particular groups with particular interventions. And it's one of the levels at which financial and operational performance is controlled. And then sometimes you'll see another level referred to, which is neighbourhood, and this can be a sort of, it's 250 to 500,000 population, and it could be like the primary care network, community-based services level. Next slide, please. This is taken from North East London ICS documentation. I'm not going to talk about it in detail because Stephanie will later. What I wanted to flag up was we're told that these are an ICS is a bottom-up approach, and in fact it's far from the case. It's this inverted triangle, what I see as an inverted triangle, is the wrong way up. You really have the ICS board up at the top, so it's the traditional hierarchy. Next slide. So this slide comes from the recent government proposals for legislation, and what this will do is bring back the Secretary of State for Health and Social Care and various ministers and give them far more powers than they've had since NHS England was set up, and it will clip the wings of NHS England. So you have those levels. The Secretary of State is going to be able to intervene where there's local reconfiguration. So there are all kinds of ways that the previous system will be bypassed. And I think people are very concerned about what that might mean. So within that sort of hierarchy, you've got the integrated care system, and the government plans are different from the NHS England ones in that it's proposing a dual system. So you have two statutory bodies now, which means that they can work legally, which they couldn't before. One is the ICS NHS body, and I'll come back to what the functions of these are in more detail. And the other is an ICS Health and Care Partnership, which is where you have the representatives from the NHS, local authorities, Health Watch, health and wellbeing boards and so on. They're sort of meeting at that level. The NHS body has a a board of directors. I'm not sure that the Health and Care Partnership has a board of directors. And I'm not sure what the relationship is between these two bodies, because the ICS NHS body is the one that determines the strategy for the ICS, and it also sets up the Health and Care Partnership. So it doesn't seem to me that they're exactly sort of equal in terms of their standing. And then you've got the providers beneath them. The other point I'd make with this slide is that, you know, the red arrows are about control and the green arrows are about accountability. I can't remember anything really that's said about public accountability in the government paper. There may be, you know, a slight reference somewhere, but it's really not given any attention. Next slide, please. So this is to give a bit more flesh to the bones. The ICS NHS body produces a plan, a strategy to meet population health needs, and I'll explain that a bit more in a bit. It produces a capital plan. It has a duty to meet the system's financial objectives. It takes on commissioning, as far as I can see, and CCGs, the clinical commissioning groups, just vanish. And they have to, the NHS body has to have regard to the local health and wellbeing boards and to the plan that the Health and Care Partnership sets up. So I don't know what have regard means, you know, whether they can just look at it and take no notice of it, or quite what it means. It's not specified. So the Health and Care Partnership produces a plan as well, which is about addressing the wider health, public health and social care needs of the population. And then, although this is described, you know, that each ICS is allowed to sort of sort out at the sort of Health and Care Partnership level how it wants to plan and deliver services, they're still tightly constrained. All the organisations within the ICS are tightly constrained. The plan, the ICS NHS body plan, is a binding plan on all organisations. There is a legal duty to collaborate. The NHS proposals talked about no veto for organisations. I think the legal duty to collaborate is the same sort of thing. And there's a system control total, which means that each organisation within the ICS has its own financial control total that it has to keep to. But at the same time, all the organisations are collectively responsible for keeping within the system control total for the whole of the ICS. I think that's as well as I can explain it, so I hope that's fairly clear. Next slide, please. So on to population health approach. It seems to me, there's this, I can't remember where I got this quote from, but there's a complaint in one of the documents that funding is skewed towards health services providing treatment. And it seems that what's happening is that the NHS is being changed from a health system or health that delivers universal comprehensive care to individuals that is significantly led clinically. I mean, we had CCGs, for example, that were supposed to be clinically led and so on. When we're moving from that to a population health model, which is concerned not with the sort of needs of individuals, but with the health of an entire population. So it looks at the risk for the entire population and not high-risk individuals. It's concerned with reducing ill health, so a lot of it is about prevention, but it's also about changing health behaviours and lifestyles. It's about improving health outcomes and well-being. There's a lot of reference to well-being without really describing what that means. Action on wider determinants of health, which sounds good. Commissioning is about achieving population health outcomes, and that this all requires an integrated health and care system to achieve it. Next slide, please. And one of the main tool really for achieving this population health approach is population health management, which has been called the critical building block of integrated care systems by NHS England. I don't fully understand what population health management is, and there are also many definitions of it. But what I do understand of it is that it uses massive data sets, which it brings together. The data comes from the NHS and beyond, social care, all kinds of different sources. And it uses that data to identify specific groups with particular needs within a population. And it allows for targeted interventions to be designed. And then I think what's sort of more, another aspect of it is that it's used to help set budgets and to determine care levels. It also allows more private sector involvement, not least because of the capital investment that's needed for all the technology that's required, for all the kind of digital infrastructure. And it also sets up systems that could be invaluable in future for private insurance companies. Next slide, please. What's not been sort of thought about much in the discussions I've been party to so far are the workplace issues, which I think are considerable. We've got the NHS Confederation, which, if I can find the quote, is the authentic voice of NHS leadership. They're talking very much about powers over the workforce, the funding of workforce governance and so on is brought down to ICS level from a national level. And I think what that's signalling is, you know, an end to, it's a fragmentation of the current system and an end to agenda for change and sort of equal pay for equal work. I think it's also got issues for unionisation. NHS England has talked about flexible working across clinical and non-clinical boundaries. And it also refers to an agile workforce and the expectation that there'll be arrangements for sharing workforces and passporting people, allowing the workforce to be deployed at different sites and organisations across and beyond the ICS. So I think that raises different issues, for example, what it means for an individual who decides to work in a particular place and then has different travel plans and so on. What it means for team building, I've no idea. So it looks as if it's yet another way in which the NHS is going to be fragmented. And there's also in the government proposals plans to, in future, to deregulate professions. So I think that's incredibly worrying, with no discussion of you know, the safeguards. And I think what that's talking about is increased digital decision making is going to mean they can dispense with a lot of healthcare professionals, really, and downskill the workforce. So, next slide, please. So that's just one issue for campaigning around workforce issues. There are also issues about accountability, the unequal partnership, for example, with local authorities, between the NHS and local authorities. But what I'm just going to focus on for the last bit of these slides is the potential for increased privatisation. So next slide, please. One of which is comes from legislative change. So Carol mentioned about the recent proposals and that they don't actually mean the end of competition. What we'll still have is an NHS market, but if certainly the NHS England was specifically talking about removing Section 75 of the Health and Social Care Act of 2012. And this would at the same time revoke the procurement, patient choice and competition regulations. So we'd still have a market in NHS services, but it would be turned into an unregulated market and so more attractive to private companies. And at the same time, removal of Section 75 would remove the NHS from the remit of public contract regulations. So the ICS could then choose to award a contract directly to a provider, or it could, if it chose, use a more formal procurement process. So we've seen with COVID how with a relaxation or abandonment of the procurement process, the rapid increase of corruption and cronyism. So I think we can foresee what might happen there. Next slide, please. The other key element of privatisation is the health systems support framework, which I'll call the framework. And this exists already, and it's there to support all kinds of different NHS organisations. It's the collection of various organisations that provide services that are seen as the kind of innovative go-to services that the NHS England has accredited. I'm not sure what the criteria for accreditation are. And they cover a whole range of services, so it can be digital tools to support system planning, patient record systems, consultation on transformation and change, all these sorts of things. It's divided into 10 different lots that cover different kinds of services. But it's absolutely crucial when it comes to the development and the management of ICSs and to this shift towards population health management. Next slide, please. So this is the just a random choice of one of the 10 lots within the framework, which focuses on informatics, analytics and digital tools. And the organisations within Lot 5, accredited in Lot 5, the ones that are marked in green are the NHS organisations, and the rest are private organisations, and you can see the usual suspects here. We've got Carnell Farrer, Dr. Foster, McKinsey, IBM, Optum, you know, all the usual suspects there. The 10 lots altogether, they contain about, I think it's 83 at the last count, accredited organisations, of which the vast majority are private companies, and a significant number of those are these big multinational companies. Next slide, please. So this is to sum up. I found this quote from the King's Fund, which I think is quite, I don't know if it's ironic or how you describe it, saying that an ICS is an NHS body that must not behave like an NHS body. And I think you can interpret that in more than one way. What ICSs are doing are fragmenting the NHS, they're increasing the presence and the influence of private companies. You can have private company representation in theory on the ICS board. They're certainly involved in the partnership, the health and care partnership level. You've got the influence or the dependence of the ICS on the framework. You've got a deregulated market if the legislation goes through, and a deregulated workforce, possibly, an increased reliance on tech companies, which are going to have access to all kinds of data, and there'll be relaxation of regulations on data sharing as well. So all in all, there's a sense that the NHS as we know it, as this universal comprehensive system of healthcare for individual patients' needs, is being turned very much into something else. It's sort of being hollowed out, and what we're getting is this very sort of data-driven approach to population health, which really looks at what's good for the population and not, so it's different in that sort of sense, but it does raise the question of who decides what's good and who for. And on that rather confused note, that's it. Thank you.
So, Carol, do you want to answer? Have we got time to answer questions now, or there's a couple of really straightforward, really helpful questions in the chat at the moment?
You're muted, Carol.
Yeah.
Okay. Yes, Coral, do that.
Yeah.
I'll ask a couple of questions.
So firstly, very importantly, will we send out notes after the meeting? I think that's a good question.
Well, we could send out these slides, and
Yeah.
at the end of this event, we're going to stick up a screen full of links that you can photograph that will give you lots more information that you can go and look at.
Okay, great.
I'm also going to be writing something which covers this, so I can make that available as well.
Okay, thanks. And then there was a question about where can we see all the list of practices, but I think if you just look up AT Medical, it shows them all, as far as I know.
AT Medics.
Yeah.
Yeah.
Yeah. AT Medics, is that? Yeah.
Yeah.
And then
Okay,
the question, is accountability joint between the NHS and Health and Care Partnership? That's unclear, isn't it? You mean NHS England and Health and Care Partnership?
Or between the NHS body, the ICS NHS body, and the Health and Care Partnership. Is that the question?
I think
that's
so.
the
It's
question.
hard to know what we mean by the NHS now after all of this, isn't it?
Yeah, it was the diagram that you showed where it had the two bodies almost side by side, and it wasn't clear. I was thinking, how integrated is it if those are not jointly accountable?
Yes, I mean, I don't know that that's clear. I mean, they're accountable, I think, to the board. As far as I know, there's only one board, and that's the board of the NHS body. I don't know that there's another board governing the Health and Care Partnership, but everything is accountable in the end. Well, I suppose it's to everyone else in terms of some of the control systems that they've got. But yes, it's not the relationship between those two statutory bodies, the dual system, is not spelled out at all. And so in terms of accountability, yeah, I'm not sure what it is. I don't know if they are.
And then Mary Logan's asked, with flexible working, workforce sharing, is there anywhere that we know that this is happening?
I think these are the proposals. I don't know of it happening at the moment,
Yeah.
but it's certainly what's been flagged up as what they want.
And Sheila says, is this related to what Matt Hancock stated in a recent briefing, is a redesign of the NHS? Is this, I mean, they're flagging it up, aren't they? Yeah.
I mean, it is, except there are also other things going on as well. I mean, we don't know yet what they are, but it's part of a broader transformation, yet again, of the NHS. And also what this, these proposals don't cover are changes to social care and public health, which are also going on and haven't been released yet. So.
And who was it? Sheila asked also about the NHS-wide computer system. So what's happened to that? Does anybody know? Canvas might know. He's here. About what's happening.
Okay, so what underpins all this is a desire to bring together hospital computer systems and general practice computer systems in what's called population health systems, which mirrors the population health that underlies integrated care systems. So in London, large amounts of money are being spent on this, about sort of 2 to 3 million per year, which I suppose isn't a lot compared to what the NHS spends overall. that has three levels really. The first is to allow universal record viewing. So if you're in a general practice, you can click into the hospital as a GP. You can click into the hospital notes and see whatever you're able to see within the hospital notes, and that is aiming to be across London. So if a patient gets referred from one cancer centre to another on the other side of London, then the doctor seeing them on the other side of London won't be missing their notes from elsewhere. Then there's everything that needs to underpin the risk stratification that was referred to in the slides. So that's bringing together data from different systems so that you can say, well, this is all the information about patients with diabetes, whether it's been collected by general practice or hospitals. So you could see how many patients in East London with diabetes have got a blood pressure above a certain amount or a cholesterol above a certain amount, and produce charts and dashboards and so on, which compare, which allow people to do that. Now, the companies that are being commissioned to do this are the ones that are on that list of IT companies that were up there. In London, the main competitors are Cerner, which is a big American healthcare corporation, which already provides the medical records for many hospitals in London. So they have a system called Cerner Healthy Intent, which is meant to pull together and aggregate all this data. And the other is something that we're trying to develop in-house with open source software, which we're calling Discovery. It looks as though we're neck and neck. Discovery, which is kind of in-house software, has got purchase in Northeast London, Northwest London and Southeast London. And the commercial competitor from Cerner looks as though it's got purchase in North Central London, probably Southwest London. The rest of the country will almost certainly all be private, will all be private IT systems. They don't replace the existing IT systems, but they aggregate the data and allow for its analysis. I think that's probably all I've got time to as a quick introduction on that. I could talk for ages on it.
Okay,
Thanks. Okay.
Carol's Carol's had a round up for ages, but could we draw the questions to an end at that point, because we do need to go on after that.
Sorry, okay.
If you could unmute Carol.
We don't have any other questions now, or?
Yeah, we'll just take Carol's and then.
Oh, okay. Yeah. Yeah.
Yes, one thing about the data sets, the white paper and all the consultation documents are very clear that it's not only GPs and hospitals that should have the access to the same data sets, but that social care should be part of the same data sets too. So we're talking about having systems that work across social care as well as all levels of healthcare, which raises pretty major issues about patient confidentiality, who has access to what and so on. Coming on to the question of the partnership board and the ICS board, as Jan says, the documentation is very unclear about lots of things. It fuzzes over with, you know, nice warm words. But I think it's fairly clear that the partnership board, the local authority and NHS partnership board, is subordinate to the ICS, the NHS ICS board, which is required to have one local authority representative on it, whereas the partnership board is intended to have more local authority representation. And everybody will be tied in with the three requirements, including the overall control totals. And one effect of that is going to bind in local authority policy on social care to an overall NHS management priority. So I think social care is going to come out of this very, very badly.
Okay, thank you very much.
Okay, so
Yeah.
Coral, if I suggest that if you could, collate another batch of questions for later on.
Okay.
At this point, I'm going to put up on screen rather an interesting slide and invite you all to take a short break if you need one, and we will come back and Mary's going to do a short follow-up, just highlighting some points again, and then we're going to go on to Steph, who's going to look at the North East London ICS. So let me just show you this screen. We're showing you this screen because...
Wrong one, Carol. It's the
You
wrong
can't-
one.
Is it wrong one?
Yeah, it's the beginning of Jan's slides.
Oh, sorry, it's if I don't close it down right, seems to be. Right. There you go. So if everybody can see this, remembering Jan's others, i.e. the private sector, all the ones that are US companies in red here, but just look at how these companies that are on one of these lot lists have benefited already from COVID. And also note the Centene, which is the owner of Operos, which has just bought out these 11 GP practices. So I'll leave you with that for 2 or 3 minutes. If everybody wants to just grab a drink or take a comfort break, and then we'll come back to Mary.
Carol, can you just say what time actually we come back so that everybody knows?
We'll say, right, just let Ben back in. Right, I'm just going to invite Mary now to go get through her next part and share the slides. Okay.
Okie dokie. Thanks, Carol. So I'm going to try and summarise the risks and consequences that we've already talked about quite a bit, but I just want to try and pull them together. And to do that, I'm going to refer quite a bit to the Health System Support Framework, or the HSSF. And I'm just going to call that the framework. And as Jan said, it was a framework set up before the white paper, back in the autumn of last year, specifically to transform how ICSs deliver care. And it's clear from the work that Jan and Carol Ackroyd and others in COMP have done that the definitions associated with all the lots in the framework are much more explicit about the intentions and the risks that are facing us than anything else. And I just think you need to hear some of the jargon, which is very dense, but it just gives you a flavour of the health insurance language that seems, from what I've read, although I'm really not an expert on it, to permeate the framework. So do you want to move on to the next slide, Jan? Carol, please. Okay, so from clinical decision making to actuarial assessments, algorithms, and population targets, which is quite a provocative and alarming statement to make. But I think it's something that is a real cause for concern. So the framework, as I've said, is peppered with health insurance language, and I'm going to give you some examples. So lots 4 and 5 concern what they call intelligence. And that's defined as, and I quote, targeted population health analytics and digital tools for bit of a gap, actuarial assessments, risk stratification and impactability modelling, and clinical decision support tools. Now, don't ask me to explain what all those things mean. You know, that this really is insurance language. And I can refer you at the very end to what I think is a really good, quite a long document written by somebody in Comp who delves into this a bit more. But as and when these systems are used, there's got to be an inevitability that it will lead to downgrading of the role of clinicians, possibly especially GPs, and a threat to healthcare based on individual need that's clinically assessed. And just to name some of the companies who've been accredited under lots 4 and 5, Atos, Centene, Deloitte, Ernst & Young, McKinsey, Optum, and PricewaterhouseCoopers. It's all the lot that were in the original slides. Capitated budgets, we've not particularly touched on this, but it's something that I think is another cause for concern, that lock in health inequalities, the impact of cuts and underfunding. And in this part of London, Northeast London, we've got huge health inequalities. We've had NHS underfunding, in particular outer London boroughs, for a long time, with all the consequences that that means. And we've got 3 PFIs. We've got one at Queen's, one at the big one at the Royal London, which most people know about, and one in Newham. So we're going to have a budget that's really, really awful. And then there will be companies, some of the ones I mentioned, coming along, creaming off some of that budget to establish systems to manage demand. And under Lot 8, which is called Demand Management and Capacity Planning, and I quote again, that involves a centralised referral management hub that processes all referrals against a standardised set of clinical guidelines. And that comes back to the role of the clinician and individual, assessments of individual need. And the companies who've been accredited for Lot 8, Demand Management, are McKinsey, Optum, KPMG, Deloitte, Ernst & Young. So that's another. So we're moving away, seems to me, quite definitely from assessing individual need that's clinically assessed. We're going to have capitated budgets that just aren't going to be anywhere near enough. And then system data sharing, which we've also talked about. Lot 1, and I quote again, talks about data export in formats appropriate for integration into other systems. And that must, we've already touched on this, have huge implications for patient confidentiality and the potential for sale of data, especially as something called the patient level information costing system, which is part of the digitisation lot of the framework, will code patients to track their cost to the NHS. The other thing that I think is a real issue, which we've also touched on, is loss of democratic accountability. So the white paper is proposing that there will be a duty on the local authority and other organisations to collaborate with the ICS, and that the local authority will lose its power to refer unpopular decisions to the Secretary of State, and a power for the Secretary of State to intervene to enforce reconfigurations. And when you put all that together with the centralisation of budgetary control and decision making, I think that's got to pretty much completely undermine local scrutiny and our influence for our elected councillors. And if you're in any doubt, after all everything we've heard this evening, there's going to be a hugely increased role for the private sector. I mean, Jan went through it, and I'll just go through it again, via the framework, the health system support framework, via influence on the boards. 10 billion has been allocated by the government over 4 years for private hospitals to tackle NHS waiting lists and penalties if those waiting lists don't shrink. Via increased use of health insurance and application of health insurance systems. And just to finish, Matt Hancock said in September of last year, when he was launching the new National Institute for Health Protection and encouraging the private sector to get involved. He said, and I quote, "The idea of a divide between the public and private sector is for the birds." And I think that's where I'll finish. So there's an awful lot of risk in the NHS, to us as patients, and a lot that we need to do as campaigners. Thank you. You're muted, Carol.
Okay, I'm just going to set up the screen for Stephanie. Oh, excuse me.
Oh, I'm unmuted. Can you hear me?
Oh, we can. Now I'm going to share the screen. Off you go, Steph.
Right. So we've, I think Mary touched on the context for North East London, of sort of population health and our communities. And this bit of the evening is about what's happening already, how, to what extent has the ICS been developed in North, in our area. Can you, next slide, please?
Excuse me.
Next slide.
Yes, just a moment. It's not
Okay.
Right, there you go.
Right, thank you. So it is important to make the statement that North East London may well not be typical of other areas. I mean, there are variations between all the areas concerned, but in North East London, there's been much less, or in general, the ICS in North East London does not have currently heavy involvement from private companies, and that's not the case in some other parts of the country. So apart from that, the changes in North East London do mirror the national picture. There's been constant, a lot of name changes. The most recent before the North East London ICS, that's the current name. Before that, it was the East London Health and Care Partnership. Then changes that are happening locally reflective of national things is that the clinical commissioning groups, which is where the accountability is currently built in each borough, these are gradually being sidelined. And then there are new operating and strategy plans in line with the NHS long-term plan. Now well, across the country, there have had to be the development of integrated care systems, and the shadow ones have been trialled in North East London from October 2020, all happening very fast, very quickly. Okay, next slide, please. So the structures. Sorry, I'm marrying up my notes with okay. So we've reached the turning point in 2021. The structure is still in development, but and there isn't a logo or a website yet. So that will, I'm sure, be forthcoming. Everything's due to be formalised in April, by April. As I say, very fast changes. So now North East London wide, the structure is in place. It's North East London ICS board, the North East London ICS executive, North East London CCG. So that's the combined, all the individual CCGs, borough-based CCGs now are sort of being represented through sort of combined North East London CCG, North East London Commissioning Alliance, and Joint Commissioning Committee. It's not very clear on quite how that's being sort of collapsed and contained within the North East London Commissioning Alliance. Clinical Senate, and then there are other committees for oversight, finance and quality, and there are collaborative forums. This is, oh, so next slide please. So there are 3 local systems. This is what I've got down as, this is slide 4. Is this the right slide? Right, okay. Sorry. Right. So so the 3 local systems, this talk about place-based is not the same thing as the local systems. So the local systems, which has been what's been evolving over the past year, is that Barking, Dagenham, Havering, Redbridge are one, have been set up as one, City and Hackney is another, and West East London, a very clunky terminology, includes Newham, Tower Hamlets and Waltham Forest. So that is our bit. And these are all now being subsumed within the ICS. Then there is local authority level, which sometimes referred to as place-based, but I'm not very clear on what place-based actually means, because I think it's not specifically local authority, but maybe we can have a discussion about that. So the place-based do vary, but they are similar. And they include primary care networks, which is the GP practices grouped together and working together collaboratively, or up to a point anyway. The borough partnerships, various boards like the neighbourhood health and care and transformation boards. These have come out of sort of earlier changes under the STPs. They are evolving. And now being sort of subsumed within this new ICS structure. And then a local integrated care partnership board, as well as an executive, and these will report to North East London ICS and North East London CCG. The sort of details of the relationships and how they'll work in practice, you know, will sort of do need to evolve. The little graphic on the right, Tower Hamlets Together, just shows the partners that have come together under this previous initiative, Tower Hamlets Together. Can I have the next slide, please? Yes, so I think I said that earlier. Sorry, I'm slightly out of sync with myself. So the North East London ICS has not had very much involvement from private companies compared to some other areas. And there is this long-standing history of collaborative working, which I think we can celebrate, but we need to hold on to that. This has been done through voluntary GP networks in Tower Hamlets and City and Hackney. We'll come back to this. Collaboration between NHS and local authorities. There has been genuine collaboration and local commitment to publicly provided NHS services, but social care hasn't been involved in that. And on the collaboration between NHS and local authorities, going back a little bit, but this has been established over decades. For instance, there have been joint commissioning of services for older people. There's been joint health and social care teams for mental health, for learning disability and sensory teams, and also a history of working with the police, local housing and landlords. And this is not, you know, this is not typical across the country. So there is a local commitment to publicly provided NHS services, and our current ICS managers aren't actually promoting the private sector, and that is not typical across the country as a whole. There is strong support for a strong voluntary sector developing innovative and specialist services and a recognition of that value. Then there is the background of the new ICS board chair. Now, she is Marie Gabriel. She's not been in post very long. Although we should not be complacent about her, it could be very much worse. For instance, Marie Gabriel has always lived and worked. Sorry?
Okay, cheers, bye.
So Marie Gabriel has always lived and worked in East London. She was previously chair of ELFT, the East London Foundation Trust for Mental Health, which had a good reputation, and also other NHS bodies in Newham. And she was former chair of Newham Community Health Council. Some of you may be familiar with the CHC's Community Health Councils. They were abolished in 2003 because they were too effective at advocating for patients. So they were replaced by Health Watch, which didn't have the statutory accountabilities to them that the CHCs had. Marie Gabriel now says she wants greater patient and public participation. And she is also, very significantly for us, I think, chair of the new NHS Confederation NHS Race Observatory. I also note that in a recent meeting, she said that she is hoping for a permissive approach in setting up the ICSs under the forthcoming legislative changes to the NHS. So she is hoping there'll be less direct intervention in how the ICSs will operate. Now, next slide, please. Oh, no, sorry, it's just, no,
that's it.
Bottom one. So, does this mean that our local NHS is safe? Because there are, you know, a lot of positive aspects to how things have evolved locally, but the answer is no, must be no. We already have one Deloitte rep, and there are 11 North East London GP surgeries now owned by Operos, that was mentioned before, Operos as the UK company under the US Centene Corporation. So there are no future guarantees. There will be pressures from NHS England and future governments once they have the legal changes they want. I also should mention that there are leaked, further thing to mention is that there are leaked proposals that suggest that management consultants and company reps will be pushed onto ICS boards. Well, there's a clear threat there from these private 11 North East London private GP surgeries now owned ultimately by Centene. That's it. Thank you.
Thank you, Steph. Okay. So if I could ask Coral, if there, just to start maybe with some of any questions that are on the chat, and then we'll throw it open to anything anybody wants to ask.
There were a couple. Ross just asked, how do we counter this word integrated, given that we know that it's just a complete sham? So, and of course it sounds wonderful, so how do we counter that? And also Terry was, I think, will have a useful thing to say about the subordination of local authorities already in Waltham Forest and how that's working. I think that'd be a useful thing to say. So firstly, how do we counter integration?
So can we unmute Terry? Oh, sorry, on integration.
Yeah.
Well, can I just come in there? I
yeah.
think, that I know that some of the medics on here would certainly, I've heard Camby's on this subject, on the importance of integration. So I think that there are people here who wouldn't say that you should argue against integration, but integration on these terms is the problem. Now, I know some people have tried to get around this by talking about collaborative working or using other words. Yes, Canva is.
Yeah, so what I would say on that is that if you look at what the NHS says on their website about place-based approaches to reduce health inequalities, they make statements like, health inequalities are not caused by a single issue, but by a complex mix of environmental and social factors which play out in a local area or place. And a place-based approach recognises that to make a significant change to health outcomes at a populational level, it's necessary to not just treat disease or the causes of disease, but to address the wider determinants of health and consider the impact of psychosocial and protective factors. The NHS has a role to play, but other things have roles to play as well, such as community centre approaches, etc., etc. So there's, you can't disagree with all that. And therefore, I think that what we're trying to argue is that the delivery mechanism for that is wholesale, is a gradual and in fact quite rapid move towards privatisation, etc. So I'm not sure that we should be arguing against the integration of health and social care. What I feel that is always happens in NHS reorganisations is that the neoliberal governments, which in this case was either the Lib Lab thing under Lansley or outright Tories, use any crisis in the delivery of healthcare to promote a more rapid and widespread privatisation. So I'm not sure we should be arguing against integrated care as such, but rather everything that the speakers have outlined that are buried within those proposals.
Thank you. Carol, could you comment then, and then we'll have Terry after that. Yep.
Okay, on integrated, I think integration of health bodies is a really good thing. That's what we're actually wanting, that's what the NHS reinstatement bill would provide, a properly integrated service. This doesn't provide that. What it does is to bring private companies into the very heart of management of the NHS, as well as being providers of clinical services. So instead of having an NHS which is capable of managing the IT systems and the patient referral systems and so on, you've got a whole collection of big health corporates who are doing that. That isn't integration. That's not what we want. Then there's the separate question of whether social care should be integrated with healthcare. And I think there are huge problems with that, because the NHS tends to see social care as just a way of making sure that you haven't got any NHS beds blocked and being able to get people out of the NHS and into community services. And the reality is that social care has a very much wider remit, which needs to time with all of those social determinants of health and care. And it needs to be managed separately from the health service. But we do want an integrated service. There's nothing wrong with integration. This doesn't deliver integration. It puts together a patchwork of the worst corporates that you can imagine into the heart of the NHS.
Thank you. Terry, do you mind to talk about what's happened to local authority care in Waltham Forest?
Yes, sure. I mean, I would very
commented that he wasn't arguing about integration of health and social care, is arguing about the term integration, that can be a good term. It's not that it's necessarily, it's just how it's used when it's done. So next we've got Roy and then Mary.
Yeah, thank you. I think we've known, have we not, for a long, long while, that what they're doing with the National Health Service is based on a lie. The same as the government, everything else it's done throughout the COVID is based on a lie. They lie through their teeth. And we shouldn't forget that. And we shouldn't get too much, in my opinion, commentators on what's going on. We know what's going on. The health service is being privatised. They don't want people who are sick and ill, who they've got to spend a lot of money on getting well. That's why they talk about prevention rather than cure type of thing. They don't want. They want to look after people who are not very ill, so they can make a lot of money out of it.
That's
and
right.
I think
So have you got a question, Roy? Because
there is a question here.
Yeah.
The figures that you give for the private companies is really illuminating. My question is, and I said this at a national meeting over a year ago, what is our campaign? We can't just leave it up to local groups campaigning on this, that, and that. We need a national campaign that we're all behind and we know what we're doing. It's no use just analysing events and commentating on all these meetings and bringing up all this information. When are we going to have a national campaign?
That's talk about
question.
That. Yeah.
That's my question.
In a minute, we'll leave that as a special question. Yeah. Mary?
Okay. Yeah. Just to say that there is a national campaign. We're gearing up for a national campaign. And I will talk about it a little bit in the summing up comments. But yes, definitely, there has to be campaigning, both locally and nationally. So, okay, any other questions coming up, Coral?
Yeah, Mary.
Yeah, just a couple of things. One of the things I wanted to say that I was thinking of when you were talking, Canbiz, is that I think the whole thing about, focusing on place-based solutions to inequality is a very clever way of diverting attention from the fact that an awful lot of the inequalities in this country have resulted from government policies, austerity, cuts, you name it. So that's one thing. I just think it's a clever way of diverting it. The other thing I wanted to say as well, that although I think we have been I think quite protected in North East London, and this is just I might have got this completely wrong, but it seems to me that because of all the issues that I mentioned earlier, all the things that mean that a capitated budget is going to be a real big problem in this area, I think and I fear that what will happen is it's carrot and stick. That's how things work in terms of implementing policy in the NHS. You offer money and you threaten. That's been going on for a long time. And I think North East London integrated care partnership system is going to have to go to government, to NHS England, and say, we need some more money. And what will happen is they'll be told, okay, we'll give you some more money, but you need to get Centene involved in your demand management, because you're not doing that. You need to get Deloitte involved. That's how it will work. So whoever we've got, and I may be a bit more cynical about some other people, about the individuals who are in and around and about in our health system, but however well intentioned they are, they don't control. They don't have the control that we would like them to have, and they might like to have, and they will be forced to bring in the private sector to do all these back office functions that will bring a lot of money to these corporations. Yeah, that's what I want to say. Sorry, that wasn't a question. I realised you were asking for questions. That wasn't a question. That was a ramble. That was a ramble. Sorry.
In terms of campaigning, we've got Eve Turner here from West London, and they've been doing amazing campaigning. So, Eve, I'll ask you, I'll unmute you here.
I think you got me wrong. I am voting for a Save Our NHS, a different.
Oh, right. Oh, sorry. There's two.
The same name.
Welcome. Please. Yeah.
No, I have a question which is probably silly, but I think a number of people will argue that prevention is much better than cure. And isn't it wonderful that we are actually finally getting the community to engage with preventative measures so that people can be healthy in the long run?
Yeah, that's a good question. Yeah, Carol?
Yes, I just wanted to add something to what Mary said about the ways that the North East London ICS will be sort of taken over. And I think we have to see very strongly that this arrival of operos right in the middle of North East London is hugely significant, because this is a block of 11 GP surgeries. Now, we've got the North East London CCG, which all the CCGs merged into North East London CCG as of April. And then from April, for 1 year, the membership of that CCG is actually going to be the chair of each of the current CCGs, and it's going to be chaired overall by the current chair of the Barking, Havering, Redbridge CCG. So for a year, we're going to have sort of, you know, something that looks and feels much more familiar than what's going to come afterwards. But what is going to come afterwards? Because then we're going to have this opero sitting at the heart of our system, and it's going to insist on influence, isn't it? Because it's a major player. And I think, and I think I've read this suggestion in someone else's blog a couple of days ago, that is how Operos is operating, in fact, that it's one of the ways that is going to make sure it gets to have a huge say, you know, in how ICSs are run. So that's mine.
And Norma?
Yeah, I think it's something that Mary alluded to with the use of the data systems and algorithms and demand management. But within all of this, it seems to me that the clinicians have got lost. There seems to be very little place for clinical judgment, and I'm wondering how much power they will have. And this is something that we really need to raise. And I also wonder whether, in terms of our campaigning, that's been raised with any of the professional bodies at all. So it's just a comment and a question, really.
Carol? Do you want to? Carol Ackroyd?
Yes, I'd like to come back on Eve's point. I think it's really important, and we haven't said that. Prevention is really, really, really important. And actually, I think all of us would agree that, you know, good housing and good public health is critical to, you know, having the health system we want. But it's very deceptive the way it's being posed here. They're not actually really talking about that. What it will mean in practice is a requirement for individuals to, as they say, take more responsibility for their own health. So we will be talking about things like you can't have that hip operation unless you lose so much weight. You know, you can't have access to this other medical treatment unless you know, kind of, well, stop smoking, you know, reduce your weight, whatever, that kind of thing. As well as a real emphasis, which is in the health system support framework, on personal health budgets, which mean anybody who's familiar with social care and the way they work, it means essentially saying, well, to manage your particular health requirement, we reckon that the cost of that would be X amount, so you can decide how that X amount will be spent, regardless of whether that's actually going to solve your health problems or not. there'll be an allocated personal budget that you can spend, and if you're not, if that hasn't solved the problems, that's tough. So that's the reality of what they actually mean by prevention. It's not what we would all want to see.
Okay, thank you. Jan?
Yes, in response to Norma's question about where professional bodies are standing on all this, there was a letter that was signed by a whole group of unions and professional, some of the Royal Colleges and so on, which was in response, I think it was to when the first proposals from NHS England came out about getting rid of competition, and I think they saw it only as you know, without looking into quite what it meant, and were very supportive of what was going on. I mean, since then we've had a bit more detail from the government proposals, and hopefully they're looking at that. But I think it is, you know, we do need to get onto all those sorts of bodies and really try and make sure that they see things from our perspective.
Charlotte? Can you unmute yourself?
I had a question and an observation. The question is, what does capitated budgets mean? Does that mean that there's no enhancements for sort of social deprivation health factors? Or I don't quite understand what it means as opposed to what happens at the moment. And then the other is just, I guess, well, a couple of observations on what we've been talking about. One is that an example, I think, of this sort of personalised health and what's going to stop people going into hospital, that's illustrated in the Waltham Forest integrated care strategy, which is the one that's being relied on to say Whips Cross doesn't need as many beds as it's got now in the future, is the only actual concrete proposal, or one of the few concrete proposals they make, is to employ something like 36 more health coaches. Without really even defining what the role of health coaches are. So the concept there is that somebody will just give advice down the phone as to how you can stop being an alcoholic when you're under massive amount of stress, and therefore get healthier. You know, which is very scary, because it just shows it shows they just want to use a statistic to justify what they're trying to do, with no concept of the realities behind what actually somebody who's heading towards alcoholism was because of their work-related stress needs to actually be able to remain healthy, and also completely sidelines the existing very effective and very good community services that actually are providing a good service and preventing people going into hospital unnecessarily. You know, so it's again, it's sort of part of this deprofessionalisation. And then finally, just kind of reflection on integrated care, just from back in the day when I was practicing as an occupational therapist, which was quite a long time ago now. Integrated care, we practiced it, you know, because you had social workers as part of the team. You work closely with home care staff because you do home visits and work with them, etc., etc. So to me, integrated care comes from the nature of the teams and the bottom up, and also is entirely dependent on sufficient services being there.
Thank you. And Nick Bailey's made a comment that the social determinants of health are going to get worse as poverty increases post-pandemic, and ICSs will do nothing about this. Of course they won't, it'll just divert more money away. And John Ashley said that at a Barts meeting he asked for evidence about how these changes were going to lead to better outcomes, and there's no evidence supplied. Oh, and then someone, they said, I believe it's better. I think, and then Ashira, I think it was, asked about, should we be getting leaflets from our GPs if they've changed hands? You know, if they've been sort of sold off to the private sector. So isn't it up to the practices to let patients know? I don't know, does anybody want to answer any of those? That's all at the moment.
Coral, I wonder if I noticed because Charlotte asked about capitated budgets, and I saw an explanation from Carol in the chat, but I wonder if Jan would like to just give us, so that it's on the recording, an explanation as to what capitated budgets are and how they differ. No, she doesn't want to. Carol.
Yes, a capitated budget is a limited budget. Now, you know, people will say, well, the NHS has always had a limited budget. That is true. However, at the end of the year, the NHS has always overspent, and one way or another, government puts more money into the NHS budget. With local authorities, councillors have a legal duty not to either set a budget which is beyond the money they're raising, or to overspend, and they can be jailed if they do that. So a capitated budget is going to put a rigid cap on the spending of ICSs. And one of the roles of the private companies will be to say, this is the amount of money we've got. How can we cut back the services we're providing so that we stay within that legal limit? And that's it's a huge shift in policy.
Carol, do you want to sum up or something? There's no more questions at the moment, really. There's great comments in the chat, but not questions. Oh, here's one.
Here's one. Eva?
Yeah, I'm sorry, I seem to be asking again. The late development of, you know, all the different breaking up of the NHS brought in a huge amount of bureaucracy. However, what you have outlined appears to have even further layers of bureaucracy. Is that the case? Are we going to be even more bureaucratized, which is going to be even more costly?
Yeah, good question. Norma got a question too? Yeah.
It was just to reply to the comment that Sheila made about if GPs are taken over by private companies, shouldn't they be informing their patients? I'm guessing, I don't know, but with all the privatisations of the NHS that have happened so far, it's been masked because it's still free at the point of care. It's been under the NHS brand, and I'm assuming that the same will pertain actually, so that people won't necessarily have any idea that their GP practice has been overtaken by a private company, and the lie, if you like, of the NHS brand will continue.
And Mary, Mary Burnett, are you?
Yeah, actually, don't worry. I was going to ask to go back to that slide of Jan's that showed the two different strands of the organisation, and then I was thinking it's probably not a good idea at this time of night after nearly 2 hours. So don't worry. I'll talk to Jan about that some other time. It doesn't matter.
Anna. Anna, yeah, unmute.
She's trying to unmute. Can somebody unmute her?
I've been trying to. You should be able to unmute yourself now. Hang on, there it goes. Not working.
Okay, now, yeah.
Ah, there you are.
Okay. Sorry about that, but I really couldn't before then. Just really a quickie. I mean, it's noticeable that in Jane Milligan, the current STP chief executive who's leaving, but that in her response to Jackie's letter on AT medics, she says, well, we are, you know, all GPs are private companies, basically, but are all GPs are private, getting completely the wrong idea of the way that general practice has been organised within the NHS. And, you know, she's as a person has made a huge shift in her movement up management from supporting public services to this sort of thing. But I think that there is an aim to make everything to do everything as quickly as possible, using these sorts of excuses and at the same time covering up from the public that things are happening privately. There was one thing, the 80 medics rang the pop-up vaccine clinic in the East London Mosque. And you may have seen it on the TV, which was a good thing. We wanted to have a pop-up clinic there because of the poor uptake. But the advertisement they produced for it did not mention the NHS at all. It had 80 medics in the mosque, which I think the mosque, when they realised, is now quite upset about. But it was interesting with their, so things are creeping out that they want to advertise, just like GP at hand. They're not really pretending to be exclusively public. So there's probably a sort of bit of an ideological shift going on. But on the whole, people are trying to say everything's public and the NHS is partly private in general practice anyway. Yeah. So it's smoke and mirrors, really.
Yeah. I can see a question from Sheila about whether free treatment is in jeopardy, and I think yes, it is. I mean, I can tell. I'm just anecdotally, and I'm sure everybody else has got similar stories. I know that my mother, who is 83, has friends who have given up waiting for hip replacements and have gone private, and that's how it'll happen. It'll happen that gradually, just really quite basic things are not available. And in just the same way as huge swathes of the country, you can no longer get a public, you know, an NHS dentist. We're very lucky in London. In huge parts of the UK, you cannot get an NHS dentist for love or money. Yeah. And that's how it'll happen. It'll happen a bit at a time. And people, you know, it's like the elderly people who have got the money will go, oh, well, that's a shame. But they won't see it for what it is, which is, you know, the NHS being chipped away.
Carol, it's 10 to 9 now. Were you going to sum up or something?
I agree. I'll sum up now and then end with a screen that you can all take a photo of if you're interested in further information. But can I first say that I'm absolutely amazed that we've had 41 people here to this. This hasn't been an easy listen. This hasn't been, you know, a very easy, let's all sort of cheer together about how cross we are about things. We've actually gone for some very deep and difficult stuff. And at this point, only 2 people seem to have left. So I'm really impressed. Thank you, everyone, for coming and staying. This year is going to be the critical year. We've said 2021 is the year that ICSs is supposed to go live. We're seeing it's about to happen. You know, it's about to take over our system in April. So we were asked about campaigning earlier. Well, all of our individual groups, all of the health campaign groups here, the Nelson Umbrella Group and Keep Our NHS nationally are going to be making it a key campaign this year. And we know that other organisations like We Own It and 999 Call for the NHS will either be, you know, alongside us or running parallel events and, you know, campaigns. So just to say that we are very lucky here in that Carol from Hackney and Jan from Tower Hamlets are both in the national KOMP subgroup that has been working on campaigning tools and really actually researching and coming up with a lot of the stuff that's been shared tonight, but also coming up with campaign tools that can be used across the country. And I can tell you that already on the KOMP national website, there are template letters to send to local authorities. There's going to be, the petition is going to be launched shortly. There's a leaflet or 2 leaflets and model motions for people to take to their local branches of political parties and their local union branches. There are also a lot of detailed articles and resources on the KOMP website. So just go look at them, be ready to share them when the time comes. But in the meantime, you know, every single one of us has to talk to everyone we know about this. You've got to bore your family and friends. You know, bore people you haven't spoken to for years on Facebook, get active on Twitter, and start talking to your union or your branch of the Labour Party. Share the recording of this session. Once I've sorted out the file, it'll be enormous, but I'll be able to send it via WeSend It if people ask for it. And then, of course, all of our groups are going to have to think about public events, whether we, you know, do something together as Nelson, or we decide to do things in our own local areas, maybe both. So again, thank you very much, everyone. And I'm going to end by putting up the slide with the links, and I'll leave it up for a while before I close the meeting, so you've got time to just photograph it.
Thank you so much, Carol and Jan and Stephanie and Mary and everybody who's organised it. It's amazing. And you've tried to make a really difficult subject able to be understood. Scary, but it's we have to understand it. Thank you very much.
And thanks to Carol for doing all the graphics, beautiful, fantastic presentation, and Coral for helping us on the technical side.
And everybody here.
Yeah. Okay. Thanks, everyone.
Thank you. Bye.
Okay, I'm going to close the meeting. Bye.
Sorry, I'm just looking at the chat for a minute. Yeah, Haley's offered to send us, Harry has offered to send us notes.
Okay.
Harry Leach.
Thank you. Thank you, whoever that is, Harry. Yeah. Great. Okay, and thanks ever so much, Coral.
That's right, no problems.
Right, bye.
Bye.